Today and the next day, next Monday, we will discuss about the anti-cancer drugs, one of the most complicated topics of the whole of the pharmacology. So, anti-cancer chemotherapy. Chemotherapy already আমরা start করেছি। chemotherapy আমরা কি পড়েছি? antimicrobial chemotherapy, সেটাও chemotherapy, আর এটা হচ্ছে ক্যান্সার কেমোথেরাপি বা অ্যান্টি ক্যান্সার কেমোথেরাপি। দুটোই হচ্ছে কেমোথেরাপি, যেটা দেওয়া হয় কেমোথেরাপিউটিক ড্রাগ দিয়ে। এবং কেমোথেরাপি বা এই দুটোর সিমিলারিটি বা ডিসিমিলারিটি কি কি রয়েছে? এটা সাউন্ড হবে এরকম নাকি? কেমোথেরাপির ক্ষেত্রে কাছে বা দূরে কিছু করতে হবে? অ্যান্টিমাইক্রোবিয়াস যেমন একটা বাইরে থেকে এক্সটার্নাল একটা অর্গানিজম আসছে এবং তাকে আমরা কোনো কেমোথেরাপিউটিক ড্রাগ দিয়ে তাকে কিল করছি। এক্ষেত্রে কিন্তু আমাদের ইন্টারনাল কোনো সেলসই কিন্তু সেটা ম্যালিগন্যান্ট হয়ে যাচ্ছে বা ইনভেডিং করে যাচ্ছে, যেটা আশেপাশের অন্য সেলগুলোকে ইনভেড করছে। অলরেডি তোরা নিওপ্লাসিয়া পড়েছিস, তাই তো? নিওপ্লাসিয়া হয়েছে তো প্যাথোলজিতে? So you know what are the neoplastic cells and what is cancer and how the neoplastic cells invade to form one cells to another. So এখন ইনভেডিং সেলস যা থাকছে সেটা বিহেভ করে অনেকটা বাইরে থেকে থাকা অ্যান্টিমাইক্রোবিয়াল এজেন্টের মতো। এটা সাউন্ডটা হয়ে যাচ্ছে। অ্যান্টিমাইক্রোবিয়াল এবার অ্যান্টিমাইক্রোবিয়াল এজেন্ট যেমন ব্যাকটেরিয়াকে কিল করার জন্য একটানা খেলে রেজিস্ট্যান্স ডেভেলপ করে, অ্যান্টি ক্যান্সার কেমোথেরাপির ক্ষেত্রেও কিন্তু রেজিস্ট্যান্স ডেভেলপ করে। সো ফার্স্ট লেটস স্টার্ট প্রিন্সিপালস অফ দ্য ক্যান্সার কেমোথেরাপি। অ্যান্টি ক্যান্সার কেমোথেরাপির ক্ষেত্রে ফার্স্ট আমাদের মনে রাখতে হবে যে ক্যান্সার বিভিন্ন রকমের হতে পারে। অলরেডি দেখেছি সলিড ক্যান্সার হতে পারে বা হিমাটোলজিক ক্যান্সার হতে পারে। কিছু ক্যান্সারের মধ্যে যে সেলস গুলো থাকে সেই সেলস গুলো কিন্তু গ্রোথ রেট ভ্যারি করে। কোন সেলস হচ্ছে মোর ডিভাইডিং দ্যান দ্য আদার সেলস, এবং সেই গ্রোথ কোন একটা সেল সাইকেল অলরেডি তোরা পড়েছিস সেল সাইকেল বায়োকেমিস্ট্রি এবং ফিজিওলজিতে। সেল সাইকেলের বিভিন্ন স্টেজে কিন্তু এই ক্যান্সার কেমোথেরাপিউটিক ড্রাগগুলো কাজ করতে পারে। এবং ব্রডলি আমরা যদি এই কেমোথেরাপিউটিক ড্রাগগুলোকে ভাগ করি, দুটো হতে পারে। একটা হচ্ছে সেল সাইকেল স্পেসিফিক ড্রাগ, মানে সেল সাইকেলের নির্দিষ্ট কিছু স্টেজে কাজ করতে পারে। আরেকটা সেল সাইকেল নন স্পেসিফিক ড্রাগ, মানে যেটা হচ্ছে বিভিন্ন মানে ইরেসপেক্টিভ অফ দ্য cells present in different types of the parts of the cell cycle, it can act. So let's discuss this. Cancer or neoplasia, you already know about this. So here happens unregulated cell division. So unregulated cell division ultimately leads to invading of the neighboring cells and then metastasis to the distant sites. So all this comes under the neoplasia by cancer. So neoplasia may be benign or malignant. Benign means that is restricted somehow, but malignant is that is disseminated further. Benign, malignant. So there are different types of the cancers like carcinoma, sarcoma. Already we have said about the different hematopoietic cancer like leukemia, lymphoma, plasma cell dyscrasia, etc. So all these are cancers and all these can be tackled with the cancer chemotherapy. So cancer chemotherapy is the treatment that involves the use of drugs to destroy the cancer cells. The basic motto of the cancer chemotherapy is to, as far as possible, destroy all the malignant cells. Other modalities of the cancer treatment are surgery and radiation, and usually now a mixture of the different treatments are usually employed for the management of any cancer. মানে সার্জারি, রেডিওথেরাপি, কেমোথেরাপি তিনটেই দেওয়া হয়। কোনটা আগে দেওয়া হবে কোনটা পরে দেওয়া হবে ডিপেন্ডস আপন দ্য ক্যান্সার, ডিপেন্ডস আপন হাউ মাচ ইট স্প্রেডস। For example, if there is a large bulking solid cancer, ফার্স্টে সার্জারি করা হয়, তারপর কেমোথেরাপি বা রেডিওথেরাপি দেওয়া হয়। কিছু কিছু ক্যান্সারের ক্ষেত্রে যেমন হিমাটোলজিক ম্যালিগন্যান্সির ক্ষেত্রে আগে কেমোথেরাপি বা রেডিওথেরাপি দেওয়া হয়, তারপর ক্যান্সার তারপর সার্জারি করা যেতে পারে। মানে অ্যাডজুভেন্ট বা নিও অ্যাডজুভেন্ট কেমোথেরাপি একে বলে। নিও অ্যাডজুভেন্ট কেমোথেরাপি হচ্ছে যখন সার্জারির আগে আমরা কেমোথেরাপি দেব, আর অ্যাডজুভেন্ট কেমোথেরাপি হচ্ছে যখন সার্জারির সাথে বা সার্জারির পরে কেমোথেরাপি দেব। সো অ্যাডভান্সেস ইন ক্যান্সার কেমোথেরাপি বিফোর 1940 there was no treatment. Surgery was only modality of the treatment before 1955. Radiotherapy came in these decades 55 to 65, and then chemotherapy comes after 1965. So basically the era of the chemotherapy came after the discovery of the X-ray by the Röntgen. And then the discovery of the different animal models of the cancer chemotherapy came, and then different other cancer drugs and how the cancer cell behaves in the different cell cycle chems, all these. So the goals of the therapy is the three, either cure or palliation, or if that is insensitive or less sensitive, how the life can be prolonged. So cure is the most important goal for the cancer chemotherapy. Cure means prolonged remission. So whatever chemotherapeutic drugs or other modalities are used, usually the cancer chemotherapy cells are killed 99.999% like this, but approximately 0.0001% remains. So this cannot be killed. Usually the similar thing happens in case of the antimicrobial chemotherapy also, but our body's own defense mechanism usually tackles the rest of the bacteria or the protozoa or the fungus. But here our own cells becomes hostile to the other cells. Our own cells becomes the invading cells, malignant cells. That's why there is always chances of the recurrence of the cancer. And this recurrence of the cancer, as far as possible, it can be lowered by different newer drugs, newer modalities of the treatment. So that is known as the cure. So cure cannot be complete cure. It may be prolonged remission. Palliation means shrinkage of the evident tumor or alleviation of the symptoms and prolongation of the life. So if the cure or prolonged remission cannot be done, then palliation, that is decrease of the different pains or other problems that can impair the quality of life of a patient, that can be done by the cancer chemotherapy. And last is, if the cancer is insensitive to every modality of the treatment, then the motto is how much the life can be prolonged. So for example, cancer esophagus, cancer stomach, squamous cell carcinoma of the lung, pancreatic cancer, melanoma, colorectal cancer, these are very virulent cancer. So in most of the cases death happens within 3 to 5 years, like that. In some cancer something more or less. In pancreatic cancer stage 3, usually death happens within 6 months. So the modality of the treatment is how much the life can be prolonged, how much palliation can be done, that is if there is severe pain, how the quality of the life can be improved. All these are part of the cancer chemotherapy. So the aim of the therapy, adjuvant therapy, what I am telling, one of the main basis of the treatment now. So previously only one drug is used. If the cancer is not sensitive to one, then the other drugs are added. But now the motto of the treatment is we have to start with the different modalities of the treatment together. So this is known as the adjuvant chemotherapy or neoadjuvant chemotherapy or combination chemotherapy, like this. So adjuvant chemotherapy, one of the main basis for mopping up residual cancer cells including metastasis after surgery, radiation, immunotherapy, etc. And it is routinely used now and mainly used in solid tumors. So remember, adjuvant means here the chemotherapy, that is the chemotherapy drugs are given after or with surgery or radiotherapy. So after it is mainly done in case of the large solid tumor or bulking tumor, bulk. So first surgery is done, then the chemotherapy is given so that the number of the cells that can invade will be decreased. The problem characteristic of the cancer cells are the problems here, because the cancer cells divide rapidly. Cell cycle is accelerated. So cell cycle, you have known, the cell cycle is different from different types of the cells. For example, neurological cells, the cell cycle, and the hematopoietic cell cycle are different. But whatever may be the duration of the cell cycle, in cancer, the cell cycle becomes accelerated so that the cells become more in the synthetic phase. So more and more duplication of the DNA happens, more and more newer cells are generated. So that is the problem. And cell-cell communication is also altered because there is always a feedback mechanism between the cells or between the different tissues. So if there is more division in one cells, the other cells nearby can give some feedback inhibition signals to restrict the growth of the these cells. But in case of the cancer, these restriction signals become lost, and this may happen due to the presence of different proto-oncogenes. These proto-oncogenes becomes activated, the growth inhibitory signals are ultimately not functioning. All this leads to more growth of the cells. Uncontrolled proliferation happens and invasiveness, invade the nearby tissues. That is the most problematic part of the cancer. This is also important for your pathology also. You have heard the invasiveness, the most important characteristic of a malignant cell, and ability to metastasize. This is the last. Ultimately, it can metastasize anywhere, and if the metastasis happens, the cancer have been progressed much more. So the general principles and what I am talking, it is analogous to bacterial chemotherapy, but the difference is selectivity of the drug is limited. In antimicrobial chemotherapy, usually we are targeting some bacterial metabolism or bacterial protein synthesis so that the other host cells are less affected. But here, the host cells as well as the invading cells all are part of our cells. So when we are using the drugs, it can nonetheless affect the other normal cells also. So that is the problem of the selectivity, and that leads to severe toxicity of the anti-cancer drugs. You can remember in the general pharmacology that there are different types of the trials, phase 1, phase 2, that is important, phase 3 trials. So phase 1 trials is usually done in case of the healthy volunteers. This is also asked in the questions. But only in case of the some severe toxic drugs like this anti-cancer drugs, phase 1 trial is also done on the diseased person because the healthy person cannot tolerate because of the severe toxicity of the drug. No or less defense mechanism. So defense mechanism, when there is infections from the outside, there are our own innate defense mechanism. There is immunity. This is known as the innate immunity. But that immunity is not present when there is cancer. All malignant cells must be killed to stop the progeny, and survival time is related to the number of the cells that escape after chemotherapy. So our motto is the more number of the cells should be killed. And different subpopulation of the cells in a malignant tumor differ in rate of proliferation and susceptibility to chemotherapy. So it is not such that in whole of the cancer cells, all these cells are responsive to the chemotherapy in the same level. So the responsiveness as well as the resistance of the cells to the chemotherapeutic drugs are different in the same cancer population, same cancer cell population. Complete remission should be the goal, what I am time and again saying, done until the drugs are used in maximum tolerated dose. Again, the maximum tolerated dose is different for different individuals. One individual can tolerate same dose, another individual cannot tolerate this. Formerly single drug chemotherapy is used. Now the combination chemotherapy is used. Usually 2 to 5 drugs are used in combination. So how these drugs are usually selected in case of the cancer chemotherapy? Drugs known to be active as single agents are usually combined together for use in combinations. For example, some drugs are active against specific some cancer, but it is not effective against the other cancer. So all these can be combined together. Drugs with different mechanism of actions and with additive or synergistic cytotoxic effects on the tumor should be combined. So the different mechanism of action so that the different tumor cells can be targeted. Drugs with different dose limiting toxicities. So if the toxicities are similar for the different drugs, if these are combined, the toxicity will be more. So the toxicities should be different. Drugs should be used at their optimal dose and schedule. So optimal dose, if it is subtherapeutic dose, the drug will not act. Should be given at consistent interval, and the treatment free period should be as short as possible to allow for recovery of the most sensitive normal tissues. So usually chemotherapy is given in cycles. Cycle means a short burst of the chemotherapeutic drugs are given, and there is some gap between 2 cycles so that the normal cells that are affected by the toxicity of the chemotherapeutic drugs usually comes out of this toxicity. Drugs with different patterns of the resistance should be used to minimize cross resistance. So resistance is the problem like that of the antimicrobial chemotherapy here also. So if these are combined, the resistance is also decreased. So these are the principles to select the anti-cancer drugs. So this is the cell cycle. The most important, you have read about this in the biochemistry and physiology. So you can see G0 is the resting phase, when the cells are resting, and then the cells goes into the G1 phase. G1 phase is the preparatory phase for the synthesis, where the different metabolic agents are usually formed, and then the cells comes to the synthetic phase, S phase. So here the DNA synthesis happens. So S phase, the chromosomes are duplicated, so DNA is copied, 2 DNAs are formed. So S phase is where the duplication of the DNA happens, and after that it enters into the G2 phase. G2 phase is again the preparatory phase for the cell division. So the DNA has been duplicated, now the cell has to be divided so that the number of the cells will increase. So this is the preparatory phase for the cell division, and this is G1 is the preparatory phase for the DNA duplication. So after G2 it enters into the mitotic phase or M phase. So in the M phase, the chromosomes are separated, segregated to the daughter cells. You know about how the replication happens, and exactly two cells are formed. And after that, the cell can go to the G0 phase, or that is the resting phase, or again it can come to the G1 phase. So in case of the cancers, the cells usually goes again to the G1 phase. The G0 phase is minimal in case of the cancer cells, so that there will be more and more cells are formed. This is ultimately, this cycle is continuing. So this cell cycle, again the same thing, the synthesis of the cellular components required for mitosis happens in the G2, then comes the mitotic phase, and then it goes either to the G0 or to the G1 phase. G0 is the resting phase, G1 where the enzyme synthesis for the DNA synthesis happens, and S is the maximum part of the phase where the DNA replication happens. So the cancer chemotherapy drug usually acts at the different parts of this cell cycle, and this cancer, by means of the different trials or different research, we have seen that different cancer cells are present in the different parts of the cell cycle. So accordingly, different drugs can be used. So after all this we have discussed, so the fraction of the tumor cells that are in the replicative cycle, that is the growth fraction, influences the susceptibility to most cancer chemotherapeutic agents. So what happens? Some part enters into the G1 phase, some part goes to the G2 phase, and this can be expressed as a ratio. This is known as the growth fraction. So growth fraction, if the growth fraction is more, that means more cells are enters within the G1 phase from the M phase. So ultimately growth fraction will be more for cancer, and again between the different cancers, some cancers have more growth fraction cells, some cancers are less growth fraction cells, and accordingly some cancers are more aggressive, some cancers are less aggressive. So this is known as the growth fraction, and ultimately this also influences the susceptibility to most cancer chemotherapeutic drugs. So there are some cell cycle non-specific drugs and cell cycle specific drugs. Cell cycle specific drugs are effective for high growth fraction malignancies, because high growth fraction means the cell cycle is continuing in different stages. So here the cell cycle specific drugs are very active. Cell cycle non-specific drugs are mainly active against the solid tumors. In solid tumors, the growth fraction are less, so that kill tumor cells irrespective of, or they are cycling in different phases or resting in the G2 phase. Okay, so you can see these are the example of the different drugs. So these are the, you can see the mitotic phase where the cell duplication happens. Here mainly acts the taxanes and the vinca alkaloids. Vinca alkaloids, there are 3 vinca alkaloids, very important drugs: vinblastine, vincristine and vinorelbine. Vinblastine, vincristine and vinorelbine, these 3 are known as the vinca alkaloids that acts on the mitotic phase. Another is the taxanes. Taxanes example is docetaxel and paclitaxel, that is also effective on the mitotic phase, and in addition it also acts on the G2 phase. So taxanes and vinca alkaloids. Okay, then in the G2 phase taxanes is active. Apart from this, the epipodophyllotoxin derivatives is also active. Example is etoposide and teniposide, and some other drugs like bleomycin is also active. So bleomycin, etoposide, teniposide and the taxanes, these are active on the G2 phase. This S phase, there are different drugs that are effective against in the synthetic phase where the DNA duplication happens. For example, topoisomerase 1 inhibitors, example topotecan and irinotecan. Topotecan, irinotecan, these are active in the synthetic phase. Antimetabolites, very commonly used. For example, you have heard this name methotrexate. So methotrexate is already the drug of choice in case of the rheumatoid arthritis. Okay, so methotrexate is also an anti-cancer drug, very important. So this is effective in the synthetic phase. Purine analogs, pyrimidine analogs. Purine analogs example is cladribine, fludarabine, mercaptopurine, thioguanine, pentostatin, etc. Okay, so purine analog, the most commonly used is the mercaptopurine, cladribine, fludarabine. Pyrimidine analog example is the capecitabine, cytarabine, gemcitabine, fluorouracil. For within this fluorouracil or 5-fluorouracil, 5-FU is very commonly used. Hydroxyurea, hydroxyurea is another anti-cancer drug which acts in the synthetic phase. On the G1 phase, different hormonal agents are active, we will discuss later, and other drugs like asparaginase, peg asparaginase, these are active on the G1 phase. Okay. So these are the differentiation of the anti-cancer drugs according to their action on different parts of cell cycle. This is easy to remember. The same thing, this is all the cell cycle specific drugs. Now coming to the cell cycle non-specific drugs. So already we have seen cell cycle non-specific means these drugs can act irrespective of the cells present in the different cycles, and usually it is used when the growth fraction is less in solid tumors. For example, alkylating agents, very commonly used alkylating agents, example is cyclophosphamide, very common, carmastine, busulfan, lomastine, melphalan, thiatepa, melchlorvitamin, etc. So these are the alkylating agents. Most common is the cyclophosphamide. Then comes the anthracyclines. Within the anthracyclines, the most common are the doxorubicin and daunorubicin. These two. Apart from this, there is epirubicin, idarubicin, mitoxantrone, etc. Then comes the antitumor antibiotics. So these are basically antibiotics, peptide antibiotics that are effective against the cancer. Example is dactinomycin, mitomycin. Camptothecins. Example is irinotecan, topotecan. Platinum analogs like carboplatin, cisplatin, oxaliplatin, etc. So these are mainly the cell cycle non-specific agents. So the cell cycle anti-cancer drugs, already we are discussing this. So slowly growing tumors with a small growth fraction, example carcinoma of the colon, non-small cell lung carcinoma, are less responsive to cycle specific drugs. Okay, so they are more specific to the non-specific drug. More effective are agents that inflict high levels of the DNA damage. For example, alkylating agents or those that remain at high concentration inside the cell for extended period of time, like fluoropyrimidines. So alkylating agents are cell cycle non-specific drugs, but they causes a high degree of the DNA damage. That's why they are very effective in different types of the cancer. It is not such that the cell cycle non-specific drugs are less active. So these are just differentiation according to their action on the cell cycle. So the clinical benefit of the cytotoxic drugs primarily been measured by the radiological assessment of the drugs. So what is the tumor size, what is the metastasis size, what are the newer targeted agents, how is the tumor growth, what is the growth fraction, what is the pharmacokinetics, all these are involved in selecting the drug. Tumor stem cells usually exhibit the same resistance to chemotherapy, radiotherapy, oxidative insults, and they are the significant barrier to the cure of neoplasm. So tumor stem cells, so the first cells, from the stem cells the newer tumor cells are formed. So they are become very resistant ultimately with the continuation of the chemotherapy. More recently, stem cell component of the tumors are growing interested because the different newer monoclonal antibodies are now prepared. They are targeting the stem cells of the cancer. So that this is the solid tumor life cycle. So you can see just giving a nutshell. So from just one cell, it gives us so much bigger. So from the malignant transformation, you can see the tumor size grows approximately 1 millimeter cube, weight approximately 1 milligram, to ultimately tumor size 1 cc, weight approximately 1 gram, and that contains approximately 1 billion cells. So from 1 cells it can comes to the 1 billion cells. Okay, so by this the tumor mass ultimately increases. So tumor mass changes from 1 kg to 10 kg here. So ultimately this change is different from the different cells. So different cancers. So some cancers are aggressive, some cancers are less aggressive. This is for the solid tumor where we can weigh the weight of the tumor. So the neoplastic cell burden. So we are talking of the cell burden. What are the number of the cells? How it can be killed? So up to 10 to the power 12 tumor cells throughout the body at the time of death usually happens. Usually diagnosis happens when there is 10 to the power 9 cells. So this is the common dictum. So 10 to the power 9 cells means approximately 100 crore cells. So when usually we diagnose a cancer, for example very common cancer, breast cancer or uterine cancer, prostate cancer, etc. When we are diagnosing first, already there are approximately 10 to the power 9 cells, 10 to the power 9 cancer cells, okay, dysregulated cells are there. And when it reaches approximately 10 to the power 12 tumor cells, usually the patient dies. So we have to stop this within this 10 to the power 9 to 10 to the power 12 like this. So usually debulking can be done when there is solid tumor. So when there is a solid tumor we can debulk this. For example, uterine cancer, there is large uterine palpable mass, we can just hysterectomy can be done. So by means of debulking, approximately 90% tumors can be removed if there is solid tumor. Still there is 10% left. So 10 to the power 9 becomes 10 to the power 8. Just this is 10 crores become, and this is known as the log kill. So how much log? So it is usually expressed in the logarithmic scales. So log kill 1, log kill 2, usually it is done. So this modality is given, log kill 2 is done like this. Okay. So there would still be up to 8 logs of tumor cells, and these tumor cells are usually resistant to the different types of the drugs, pharmacological sanctuary, because it can be lost within the CNS or testis where it is very difficult to kill, or it can enter into the G0 cycle. So it can enter within the resting state. So ultimately it is again very difficult to kill, but this can be activated at any time. So an effective drug is 99.999 something that, but not 100%. That is the problem. Still that is left, and this left is present in the G0 phase or some within some tissues, and again this can be activated at any time. So the scheduling of this agent is particularly important so that more and more cells can be killed. So the tumor kinetics, the same thing what I am talking. The tumor's characteristic exhibit, just remember the name, this is a sigmoid shaped Gompertzian growth curve. The curve is like this. So this is known as the Gompertzian because he is the one first describes this. This is known as the tumor kinetics, how the tumor cells changes. So this is a sigmoid shaped curve, So at the first there is slight increase in the number of the cells, and in between this you can see this is a straight line, slant line. So there is tremendous increase in the number of the cells, and here the S phase is very active. So there is more and more synthesis of the newer DNAs, and more cell division is happening. So most of these cancer chemotherapy drugs are usually active. These are invented so that these are active in these areas. Okay, and then it ultimately, even if it is after the detection, it goes within the plateau. So ultimately death can happen, or ultimately it goes to the plateau like this. So this is known as the Gompertzian model of the tumor growth. Okay, and log kill hypothesis, what I am telling. So usually these tumor cells follow the first order kinetics. You have also read about the first order, zero order kinetics in the general pharmacology. The similar thing, when we are using the cancer chemotherapeutic drugs, usually a constant fraction of the cells are usually killed, not constant amount. In zero order kinetics, constant amount of something is eliminated or killed. Here the constant fraction of the cells are killed. So this is known as the log kill hypothesis. So solid cancer tumors generally have a low growth fraction, responds poorly to chemotherapy, and most cases need to be removed by the surgery. And disseminated cancer generally have a high growth fraction, generally respond well to chemotherapy. So log kill. So ultimately depending upon the tumor, we have to apply the surgery, and then we have to apply the chemotherapy, or the vice versa. So the same thing. So similarly, what I am talking. So for bacterial infections also, the similar thing happens. The log kill happens. The log kill hypothesis is also applicable to the bacteria. Usually it is told that after the 5 log kill, most of the bacterial infections or the cancer cells are removed. But bacterial cells after 5 log kill, approximately 99% removed, and rest can be taken care of by our body's own innate defense mechanism, our immunity. But in case of the cancer, this cannot be tackled because our own body cells become dysregulated. So that is the problem. So in spite of the 5 log kill, most of the cells are disseminated. There is every chances of the cancer recurrence. So the approach of the treatment. So how the approach of the treatment, what we are taking. So you can see this dark blue line. So here the infrequent scheduling of the treatment courses happens, where only 1 log kill happens. So this is the diagnosis. After diagnosis, we are giving 1 drug. Then after again after months, again another drug is given. So ultimately you can see there is increased number of the cells, and ultimately death can happen more quickly. When we are using this, you can see light blue line. Here the more intensive and frequent chemotherapeutic drugs, the combination is usually given. So if we are starting earlier, so even we have to diagnose the cancer more earlier, and we have to apply the treatment. Then you can see that is the opposite, the inverse. So it can be inverse. So death, there will not be any death. Again, the green line you can see, if there is some large tumor, we can apply the surgery. When the surgery is applied, you can see there is drastic reduction of the cancer cells. So then we can apply the chemotherapy, and then again the cancer cells become less. So it is not at this moment like that. If the cancer happens, death is inevitable. So with the advent of the newer chemotherapeutic drugs and radiotherapy is already there, and if it is possible surgery, most of the cancers can be curable. But curable means it is prolonged remission. So there is always chances of the recurrence is also there. But you can see from this we can just invert. So there is no death in these two. So this is the motto of the cancer chemotherapy. Neoadjuvant chemotherapy, what I am talking. So neoadjuvant means if it is bulk tumor, but this is very large, we can apply beforehand some chemotherapy so that it will be short, the chances of the dissemination is less, then we can apply the surgery. So if the chemotherapy is applied before surgery, this is known as the neoadjuvant chemotherapy. If the chemotherapy is applied after surgery, this is known as the adjuvant chemotherapy. So this is the difference between neoadjuvant and adjuvant chemotherapy. So these are the terms often used in cancer chemotherapy. So clinical consideration, the same thing, combined chemotherapy is useful, complete remission is the goal of chemotherapy, early intensive treatment, early intensive start to the treatment is needed. Large bulking tumors, we have to first decrease the number of the cells. Combined chemotherapy can be curative. Treatment must continue past the time when cancer cells can be detected using conventional techniques. So conventional techniques can usually employed even after the chemotherapy is continuing. So even if it is detected, we have to apply the chemotherapy. When cure of the cancer is possible, cancer treatments may be considered despite the certainty of severe and perhaps life-threatening toxicities. So here is the balance between the two. Because these cancer chemotherapeutic drugs are very toxic, so we have to balance between the survival and the toxicity of the drugs. So if the cancer is curable, then the patient, it should be a shared decision making with the patient that this toxicity, this type of some permanent toxicity can also happen. In spite of this, the cancer will be cured or very much prolonged remission. So this should be weighed. Every cancer treatment has the potential to cause harm, and treatment may be given that produces toxicity with no benefit. Therapeutic index is very narrow in most of the cancer chemotherapeutic drugs. The clinical goal is palliation. If it is, careful attention to minimizing the toxicity of the potential toxic treatment becomes a significant goal. Palliation means there are some cancer, even if now, where the survival time is very less. In spite of using surgery, chemotherapy, radiotherapy, the survival is less. Here the motto of the treatment is the palliation, as I have already discussed. Palliation means to improve the lifestyle of the patient. So prolong the time of the survival. So if the patient survives, the average life is approximately 3 years after detection. So it can be prolonged to the 5 years. And it is to be seen that whether the patient can achieve a near normal lifestyle with the cancer chemotherapeutic drugs or not. So this is the motto of this. So if the motto is the complete cure, then we have to compromise the toxicity. But if the motto is palliation, the patient is destined to die, then we have to think about the toxicities so that the toxicity will be as far less as possible. Okay. So therapeutic integration efficacy, the same thing. These are combined. Pharmacotherapy is combined these two. Each has its own risks and benefit. Individual patient characteristics is very important, whether there is any comorbidity. For example, some may have some kidney compromise or liver compromise. In those cases, there is more chances of the toxicity with some drugs. Renal and hepatic function, bone marrow reserve, that is also the problem, because the one of the most common toxicity is the bone marrow suppression of the chemotherapeutic drugs. Other than natural history of the tumor, natural history means what is the normal lifespan of after the detection of the tumor, what is the increase of the tumor cells in that cancer, patient's willingness to undergo difficult and potentially dangerous treatment. So more and more you are entering into the patient service. Now it is becoming more important to take the patient into confidence, patient and patient's relatives, otherwise there will be problem, and there is always a chance of the problems with the cancer chemotherapy, because so much toxicity is there. On the other hand, there is survival or just increase of the life for some months. It may happen. So there are some drugs for pancreatic carcinoma. The drug has been invented, in fact, very costly, that can just increase the lifespan. The normal stage 3 pancreatic carcinoma usually dies within 6 months to 1 year. It just increases just 2 months or 3 months. But that is also maybe very important for some patient perspective or patient relative perspective. That is, the drug is invented just to increase just 3 months of lifespan. Very costly. So this is a very delicate thing about this cancer chemotherapy. Okay. The same thing, orally administered drugs are now frequently prescribed using uniform dosing for all adult patients. Dose adjustment is needed. The similar thing for other drugs. Elderly patients usually need lesser doses like this. Drug clearance always changes for the morbidly obese, renally compromised, hepatic compromised patients, etc. Molecular testing to select patients for chemotherapy is usually done now. So we can select some molecular testing or genetic testing. So which patients are more susceptible to some drugs or not. So in those drugs we can use the drugs. For example, we can test whether the CD20 is present. So here we can, the rituximab is against anti-CD20. So this is very effective. So trastuzumab, that can be useful for breast cancer where this HER2 new receptor mutation is present, for example. So we can beforehand identify those patients who will be more beneficial with these drugs. The same thing, there are some, these are some diagnostic, this is known as the point diagnostic. We can diagnose by means of the genetic testing, and to this different drugs can be given. Details is not required. Now coming to this resistance, so intrinsic or acquired resistance. Some cancer cells are intrinsically resistant to some drugs. So here these drugs cannot act. Some have acquired resistance through the time of the treatment. So for example, malignant melanoma, renal cell cancer, brain cancer, they exhibit primary resistance to most of the drugs. That's why these are difficult to treatment. In most of the cases, these are treated by either surgery or radiotherapy. Acquired means in most of the cases single drug can be resistant due to some genetic mutation. Multi-drug resistance happens when it is continuing for a long time, most commonly again due to genetic resistance like some MDR1, increased expression of the multi-drug resistant one. You can see these are more or less similar to the antimicrobial chemotherapy also. Toxicities, they are harmful to normal tissues. The dose response curve is very steep. The therapeutic index is very narrow. Low therapeutic index, particularly harmful to rapidly multiplying normal tissues like gastrointestinal mucosa, bone marrow, reticuloendothelial cells, gonads and hair cells. That's why you can see bone marrow suppression, mucositis. These are very commonly problems with the cancer chemotherapy. And effects are in dose dependent manner. With increased doses, the toxicities are more. Bone marrow depression is the most common limiting treatment. So if the bone marrow depression happens, that can be identified by just blood counts. So the neutrophil count diminish, neutropenia happens, different other blood cell count diminish. So we have to decrease the drugs or stop the drug. Buccal mucosa erosion, very common, mucositis, that can happen due to high epithelial turnover. So within our mouth cells, these epithelial cells have high epithelial turnover, that is the growth fraction is more. That's why they are also affected by these cancer chemotherapeutic drugs. That's why mucositis is very common. Nausea, vomiting can happen due to CTZ direct stimulation. CTZ is a nauseating center. In the skin, alopecia, you know all know that with chemotherapy the hair usually falls. So alopecia is the most common. In the gonads, this is also common. Oligospermia, that is the sperm count becomes less. Impotency can happen, amenorrhea, infertility, all this can happen. Lymphoreticular system, in the lymphocytopenia, inhibition of the lymphocyte function can happen. Loss of host defense. Carcinogenicity, the same thing what I am talking. The anti-cancer drugs itself, they are carcinogenic. So again, they can develop cancer in some other areas. They are toxic. So there is always chances of the recurrence of the cancer or cancer in other areas also. Teratogenicity and hyperuricemia. So this cannot be given in the pregnant and nursing mothers in most of the cases because that can be leads to teratogenicity. The fetus can be affected and also hyperuricemia. The uric acid is also increased. So we can counter the toxicities by means of the different drugs also. For example, intermittent therapy. Usually these are the different areas for we can give some drug-free intervals so that the normal cells can recover from these toxic effects. Folinic acid rescue, already you have heard about this in the methotrexate. So methotrexate causes bone marrow suppression, so we can give the folinic acid rescue folinic acid so that it has not to be converted to the tetrahydrofolic acid from the dihydrofolic acid by means of the folate reductase. So that is usually blocked by the methotrexate. The same thing. So folinic acid can be given. Systemic mesna. You will read about this in the alkylating agent. So mesna is a thing known as the sodium 2-mercaptoethane sulfonate, which is usually administered or irrigated with the acetylcysteine and with the alkylating agents. Different types of the alkylating agents usually causes hemorrhagic cystitis. So cystitis, that is inflammation of the urinary bladder, and hemorrhagic, that is blood, usually comes to the urine. So this can be minimized if we give the mesna, because there is sulfhydryl group and that can mitigate the toxicity. We will discuss this. Ondansetron is given, very commonly used to decrease the nausea and vomiting. Hyperuricemia is very common, so urocosuric agents like allopurinol is usually given. Platelet and granulocyte transfusion can be given. Because the bone marrow suppression happens in some of the cancer, there are severe thrombocytopenia and bleeding episodes can happen. So we have to transfuse from outside platelet. Similarly, if there is severe neutropenia, already in the hematology chapter, I have taken classes about the sargamostim, field gas stream. You have heard, na? Field gas stream, sargamostim. So these are the colonocyte stimulating factor, growth factor. So these are usually used as a counteracting the anti-chemotherapeutic drug. Similarly, if it is not responding, then we have to transfuse the granulocyte. Granulocyte colony stimulating factors, recovery from the granulocytopenia. So these are the variation in sensitivity. Just giving a nutshell, you can see how the different cancers are sensitive to chemotherapy. So these cancers are sensitive, very sensitive to the chemotherapy. Lymphoma, leukemia, small cell lung cancer, testicular cancer. Intermediate, somewhat, breast cancer, colon cancer, non-small cell lung cancer, and low. That is, these are very resistant to chemotherapy, like head and neck cancer, prostate cancer, some gastric cancer and pancreatic cancer. So accordingly, we have to choose the drugs. We have to choose the modality of the treatment, in fact. So to conclude, the pharmacokinetics and toxicities of the cancer drugs vary among individual patients. It is imperative to recognize the toxicities early. Those we have to individualize from one individual to another individual on the basis of the kidney status, hepatic status, age, what is the tumor, what is the approximate number of the cells present in the tumor, what is the pharmacokinetics and pharmacokinetics of the drugs, all these are involved. And if there is toxicity, what will be the measures, what will be the patients is also taken into confidence that this type of toxicity can happen. That's why these drugs are given beforehand. Prophylactic drugs are often given. This growth factor or platelet transfusion is often given prophylactically for this. Toxicities in fact involve the heart, lungs also. Heart. You have heard the name of the doxorubicin and daunorubicin. These are cardiotoxic. So they can involve the heart also. So all the organs can be affected by different types of the drugs. Fortunately, such toxicities can be minimized by early recognition and by adherence to standardized protocols and guidelines for drug use. So that is the very optimistic that newer drugs have come where the toxicity is less or the more targeted therapy. We will read about the targeted therapy is more, and the other prophylactic drugs can also be given so that the toxicity will be less. So these are about the principles of the cancer chemotherapy. So principles of the cancer chemotherapy is important. So you have to write about the cancer chemotherapy, what is adjuvant chemotherapy, what is neoadjuvant chemotherapy, what is the combination chemotherapy, what is chemotherapy in fact, and what is the similarity, dissimilarity between the antimicrobial chemotherapy and cancer chemotherapy, how the tumor cells increases and how it acts, what are the cell cycle, what are the different areas of the cell cycle, what the cancer chemotherapeutic agents act, what are the cell cycle specific drug and cell cycle non-specific drugs. These are very commonly used in the Viva also. So, name some G2 specific drug like this. So what are the drugs and how this curve, that is a sigmoid Gompardian curve, how the log kill is done. Usually 5 log kill is needed in most of the cancers to decrease to the minimum. But in spite of this, there is always chances of the recurrence. So these are the principles of the cancer chemotherapy. In the next class, we will read in the nutshell about the different chemotherapeutic drugs.